Thank you, Mr. Chairman. Thank you, Aga. Calcific tendinitis of the rotator cuff. This is a very wide subject. We'll try to summarize it. Was our work about this topic. It was published in the American Journal of Sports Medicine in 2011. First, we must discuss terminology. Regarding terminology, there is a big difference between dystrophic calcification and calcific tendinitis. Dystrophic calcification occurs in a non-viable tissue, hypovascular, at the insertion, or actually at the edge of the rotator cuff. It worsens by time. It occurs in elderly above 65. While calcific tendinitis occurs in a highly viable tissue, highly vascular, within 1 to 2 centimeters from the insertion. It tends towards spontaneous resorption. This is very important. And it occurs in the 50s and 60s, earlier on. To understand calcific tendinitis, we must understand the prevalence. The prevalence is about in the 50s and 60s, as we've just said, 50% within the supraspinatus, more with sedentary employers, and more in females, about 60% of cases, and usually not associated with a complete rotator cuff tear. It only occurs in 3 to 4% of cases. To understand calcific tendinitis, we must first understand the pathology and the natural history. It starts by repeated microtrauma leading to transient hypoxia. This leads to an increase in the protoglycan with metaplasia of tenocytes into chondrocytes. This is followed by calcium deposition within the matrix vesicles of the chondrocytes that develops later on into bone foci that later coalesce into calcium deposits. During the acute resorptive phase, there is peripheral vascularization of the calcium deposits with mononuclear giant cells and macrophages infiltration with fibroblastic formation, leading to an aggressive inflammatory action. This is associated with edema, increase in the tendinous pressure, inflammatory cell accumulation, leading to severe pain with secondary impingement or deposit rupture. In the post-calcific stage, the fibroblasts start to fill the gap. It fills the gap with first collagen type 2 that later on, within 1 or 2.5 years, maturate into collagen type 1. Calcification. We can classify it into a pre-calcific stage, calcific stage, and post-calcific stage. The calcific stage, which is the most important stage, must be defined into the formative and the resorptive phase. The formative and the resorptive phase. Clinical presentation. The formative phase, there is calcium deposits within the chondrocytes that later coalesce to form the calcium deposits. Radiologically, it's a well-demarcated chalky calcium deposit within the tendon, 1 to 2 centimeters from the insertion. Clinically, it's similar to mild impingement, very mild symptoms. While the resorptive phase, there is increased vascularization with mononuclear and macrophages infiltration, fibroblastic invasion, leading to an aggressive reaction with severe unbearable pain due to intratendinous increase in tendinous pressure due to the edema and the inflammatory cell accumulation. Radiologically, there is an ill-demarcated fluffy calcium deposit. In the post-calcific stage, clinically, symptoms starts to regress till complete recovery, and X-ray-wise, the calcium deposits start to fade away and may even totally disappear. Then it is a self-resorptive progression. It's not a progressive disease, it's a self-resolving disease. The clinical presentation. During the pre-calcific stage, it's almost asymptomatic. It's usually discovered by accident. During the calcific stage, during the formative stage, which extends from 2 to 3 weeks up to 6 months, it is mild impingement. While in the resorptive phase, which extends up to 3 months, there is severe, unbearable pain. The patient cannot sleep, even at rest. With severe tenderness, you cannot elicit any of the provocative tests. In the post-calcific stage, pain starts to regress until it totally disappears. Radiologically, in the plain X-rays, in the AP and the lateral scapular and outlet views, there is calcification within 1 to 2 centimeters from the insertion. It's never at the insertion. Ultrasonography may be helpful. You don't need an X-ray to define the formative and the resorptive phase. They are clinically very obvious. The MRI usually shows us whether there is a tear or not. There is usually thickening of the distal part of the rotator cuff, but it is more important to show whether there is a tear or not. Treatment. Treatment is individualized to each patient, depending on our knowledge about the pathology and the natural history, and our at the clinical stage, and finally, both of which would help us to determine which stage we are. Conservative treatment is always successful if the patient can withstand this painful condition. You usually use painkillers. We may use shock wave. We may use needling or puncture and aspiration, while physiotherapy actually has no role during the resorptive phase. If we need to do surgery, it is only indicated in cases where the pain is unbearable and the patient cannot wait till he passes this stage. We can do it by open procedure or arthroscopically. Arthroscopically, we do a subacromial decompression in the form of bursectomy. It is very important, as usually there is a severe inflammatory reaction. The bursa is fleshy, enlarged. You cannot see anything. You have to do a bursectomy for visualization. You may do a coracoacromial ligament release, plus or minus subacromial decompression. Calcium deposits. First, you have to identify it, what's known as the calcific bulging sign, and then localize it using a spine and needle. Then open the calcific bulge using a half-moon arthrotomy knife. You will see the calcium choke coming out. Remove as much as possible. You don't have to remove all the calcified material. You don't have to remove all the calcified material. Whenever you open this bulge, it will fade away within a couple of months. If there is a defect more than 50% of the thickness of the rotator cuff, it is better to repair it, as it has been proven to progress. Here is a small video. You open the calcific bulge in line with the rotator cuff. Then you start removing the calcific material from within the bulge. You may use curette, you may use 3.5 millimeter motorized shaver. And after removing as much as possible, you will reassess the defect you left behind. If it is more than 50% of the thickness of the rotator cuff, you have to repair it. In this case, we used side-to-side sutures, mattress sutures actually. The pain is suddenly relieved. The patient postoperatively tells you, it is a miracle, I have no pain. Thank you. So, postoperatively, the first 2 weeks, arm sling immobilizer with passive self-assisted range of motion. The second 2 weeks, you start active assisted range of motion, gradually increasing to full active exercises, avoiding excessive abduction or external rotation. The next 2 weeks, you start with strengthening exercises, follow up by Follow-up should be done weekly for the first 6 weeks, then every 6 months for the first year, then henceover annually. X-ray, immediate post-operative, then after that for every 6 months for 3 years, henceforward annually. In summary, you must differentiate between dystrophic calcification and calcium deposits. Resorptive phase is truly painful for 3 months, 3 weeks up to 3 months. Almost all cases do well with conservative measures if the patient can withstand the pain for the first period of the resorptive phase. Operative intervention is only indicated in cases who cannot stand this unbearable pain. Arthroscopic removal of as much as possible. You don't have to remove all the calcium deposits. Cuff repair is only indicated if there is more than 50% of the thickness of the rotator cuff tear. Thank you very much.